podcast listeners. This is Scott Weingart, and you are listening to the MCrit podcast. Today, I have for you the first lecture I am posting from the MCrit ED Critical Care Conference in 2014. It was an amazing conference. I'm going to be posting all of the lectures over the coming weeks, and this is the first one. It is a debate on the topic of tPA use for ischemic stroke in the emergency department. On the pro side, Andy Jagoda, my chairman of emergency medicine and one of the best medical educators out there. On the con side, the Swami, Anand Swaminathan, EM Lyceum, MRAP contributor, all-around brilliant guy. They went at it, and it was too much fun. You're going to enjoy it. Here we go.
So I figured we'd have a little debate. And I was looking for topics, and this one caught my eye because, as some of you are aware, our organization in the United States, ACEP, released the clinical policy on the idea of tPA. Now, some people, and it's the tPA pro folks, are like, this is an idiotic debate. There's no point in this. No one has any questions about this anymore. You just give the tPA. The people who don't believe in the drug, they think the same thing, but with the opposite actual result in these patients. And I think there is some degree of question that remains. I think there is some degree of equipoise. So I wanted to hash it out at the conference, especially in light of the recent policy ACEP made getting actually sent back by the council for further review to make sure that the clinical policy committee was really sure about what they were saying. Because without the emergence of too much more data, there was a shift in the recommendations for whether or not the line clinician should be administering this drug. So now I needed someone to take the pro side, and there's no one better than my clinical chair, Dr. Andy Jagoda. He is a professor of emergency medicine. He's the chair of emergency medicine here and now at multiple hospitals throughout the city. And he has made a specialty of neurological emergencies. He was the past chair of the Clinical Policies Committee. He's been intimately involved with the guidelines. And so he's the perfect pro. And he's just, one of the best medical educators out there. And then I needed a con. And I have a friend named Anand Swaminathan, a.k.a. the Swami. And if you don't know the Swami, you should start listening to his stuff. He is brilliant. He's an excellent dissector of evidence-based problems. He's an assistant professor and the assistant residency director with the Bellevue program, and such a good guy. And he was brave enough to take on the juggernaut, Andy Jagoda, on this topic. And he's not going to back down. If I had a debate, Andy, I'd just be like, oh, you're right, sir. But the Swami's not going to do that. So what the format's going to be, I'm going to give 10 minutes pro, 10 minutes con. And we're timing it, guys. I'm going to pull you off the stage. And then 5-minute counterpoints from each of them. And then you guys get to hit them with the tough questions about what you think. So let's get Dr. Andy Jagoda up here. Here's your site. Click whatever you're ready. Yeah. And I won't start the clock until you tell me you're good to go. Let's put it all the way up, sir.
All right, well, listen, thank you very much, and we'll see where we end up in 20 minutes. I'm feeling a little inadequate, I have to tell you. I don't have a Twitter account, and I don't have fancy videos, so I haven't done a crike in such a long time, and I'm not very good with pulmonary ultrasound, so I am feeling so inadequate that actually I've been thrown off balance. I'm so inadequate that I didn't even know what a cage match was. So Scott asked me to give this talk, and I'm saying, great, but I don't even know what I'm getting myself into. So let me see if I can turn it. I'm so inadequate. I am so inadequate. Of course, before I begin, I do need to give a disclosure, and I am biased. And part of this, the dilemma of this whole, don't start the clock yet, because this is still kind of introduction. But these are my disclosures. I've been involved in stroke decision-making very early on, and so I have to tell you, I've kind of drank the Kool-Aid, and I've bought into this very early on. And it kind of surprises me that we are having this stupid debate. But that's my bias. I do sit on a couple of advisory boards, and I also am a representative from ASAP at the Brain Attack Coalition at the NINDS, which is a multidisciplinary group that works on promoting stroke care. So, you know, it's like putting the fox in the chicken coop to try and make a point. But anyway, I do believe what I'm going to be talking to you about. But we're back to a cage match. I have no idea what a cage match was, so I did what everyone does, and I went on Google. And this is a cage match. So I have to tell you, this really threw me off, because now I'm really wondering, what did I get myself into? And anyway, and this is the other definition of a cage match. And I'm not much of a wrestler, and I don't know whose feet are going to be in or out of the ring at the end. I have a feeling both of us are going to be straddled right on the side of the cage, and neither of us are going to be able to stand straight. So listen, there's 3 key questions that come up. Now we can start. Now we can actually start this whole. Start the clock now. All right. So there's a couple questions that come up, and this is fundamental to the whole next 10 minutes. Does alteplase, and I'm not calling this tPA because there's only one drug approved for stroke, and that's alteplase. Does it improve functional outcomes in patients with acute ischemic stroke? That's the question you're asking. Does it have benefit? The other one is, what's the risk of symptomatic ICH, and does the risk outweigh the benefit? That's the big question. And you got to understand this a little bit, and it's hard to figure out, because if I ask you, what's the risk of a symptomatic hemorrhage after giving tPA, what are you telling your patients? Because it's not so simple to simply tell them, oh, it's 6 or 7%. It depends who the patient is and what their risk factors are. And if you're not informed of that, you're not having an intelligent or educated conversation with the patient. So we have to drill into that a little bit. And then, is there a subset of strokes that have a higher risk and a lower risk? Because that's going to help you be a better doctor to educate your patients and help give them an informed decision. So here's the key points that this is the end of my talk. Then I'll fill it in. But this is the end of the talk, really. Whether you like what I say or not, whether you like it or not, alteplase is FDA approved. It's an accepted high-level recommendation and, in essence, standard of care in the treatment of acute ischemic stroke in patients who qualify. That's the way it is. So regardless of how Anand is going to read the literature, this is the way the literature has been interpreted by major societies around the world. Number 2, the risk of symptomatic hemorrhage in properly selected patients is actually less than 2%. So who are those patients? And you need to know that so you can talk to your patients. And a decision not to use alteplase by all the recommendations, it's fine. It's okay. But I have to tell you, you better do a good job documenting your clinical decision making. And then it's okay. But no one's going to be able to help you or the patient if you can't think through it properly. So here you go. Here's the facts, and you'll use these facts to look at the literature. And because the question is really, if I don't do anything, how's my patient going to do? We're trying to figure out, does alteplase really improve outcomes? And here's the facts. Whether I do something or nothing, 25% of my patients are going to have little or no disability at 3 months. 25% are going to have mild to moderate disability, 25% severe disability, 25. So use 25%. That's the set point. So we can take all the big registries out there, all the historical data, and we can pretty much say 25, 25, 25, 25. And what I'm looking for is an intervention that's going to shift disability. The only other thing I have to tell you is you need to just understand a modified Rankin score is what we use to judge disability. A modified Rankin of 3 means I'm fairly independent and I can walk with a walker. A modified Rankin of 4 and above, I'm very disabled and I can't care for myself. When we're looking at interventions, it's not to give something and have the patient get up and walk and dance. It's to give the patient improved functionality. And if you ask me, do I want to be a modified Rankin of 4 or 3? Sign me up for the 3. Don't let me spend the rest of my life as a 4, meaning I can't feed myself and I can't walk without a walker. And I want any chance I can for independence, or I just don't want to go on. So that's kind of my passion for approaching this. So here we go. Here's the famous NINDS trial. I'm so tired of going over this, but it's the perfect journal club article, I think, for all residents, because if nothing else, the NINDS trial created a research agenda in emergency medicine that was funded by the NIH. And we should be thankful for the stroke debate because it's made the NIH aware of how important emergency medicine is to acute resuscitation. And as a result, you know, we have the NET and we have our newly formed institute with dedicated funding. Anyway, it's a 2-part series. I don't need to go into the details because I think most of you are aware of it. They're looking at 0 to 1 modified Rankin at 3 months. In the end, that's the outcome. I'll get back to that. And this graph pretty much shows you what that trial showed. But there were problems with it, and I'm sure we're going to get into this quite a lot. But if you look just visually, the visuals looking at the tan and the green are showing you at the bottom where the tPA group is and at the top where the placebo group is. And the odds ratio was 1.7 for a favorable outcome. And the conclusion was this was 2 studies combined into 1 showing favorable outcome without increased mortality. Sign me up because I want to be functional if I have a stroke. And that's what drove the whole thing. The problem is this. Lots of criticisms. This trial was a mess in many ways, and it needed real statistical analyses to make heads and tails of what was going on. Oh my God, 4 minutes are gone, and I'm not even started. But anyway, so here you go. The problem was this. In the first 24 hours, the thought was, I'll give tPA and voila, I've opened up the clot and the patient's going to be functional. At 24 hours, there's no benefit. And in fact, most of the hemorrhages are taking place not in 24 hours, but at 36 hours. Almost no one here, I bet you no one here has had a patient convert to a hemorrhagic stroke in the emergency department. It's usually taking place out, which is, of course, part of the reason Scott was saying there's lots of disruption going on in coagulation. The biggest problem with this whole trial is, even though it was randomized, the patient who gets tPA were less sick than the patients who didn't get it. So it looks like it's just by selection favoring improved outcomes in the tPA group. What a mess. But the statisticians really manipulated it, and in the end, they come up with an improved outcome, 1.7 odds ratio, and what they're saying is you need to treat 8 patients to get 1 benefit because they're looking at an outcome of 0 to 1. If you look at a 1 change in the modified Rankin, you only have to treat 1 in 3 patients. It's pretty impressive. There's not a lot of drugs out there that can show you that kind of effect. So the controversy gets very hot. And they say, this is NINDS. Genentech gave some money to the NINDS. This is a flawed study, and a statistician needed to interpret it, and they were influenced by Genentech, and so the controversy starts. And we have famous people out there like Jerry Hoffman, who's made a career of bashing this study and on, and you've heard the podcast. And so an independent group of statisticians and clinicians were asked to review the data. Now, I don't know how many of you know Lou Goldfrank, but I know Lou, and I think he's a pretty honest guy. And I don't think Lou's a very easily biased sort of guy. So Lou, along with all the other people on this slide, are identified, and they're given all the data set from the NINDS 2 trials. And I have to tell you, they came out, it isn't a 1.7 odds ratio. It's a 2.1 odds ratio of favorable outcome. Sign me up. So all this business of it not being statistically sound and manipulated and impacted by industry, I don't buy that. But there's a couple interesting things now that are going to impact you. I'm almost out of time. And here you go. We can identify patients at higher risk for hemorrhage. And this is what I tell you. If you're afraid of hemorrhage, and we all are, be wise in who you select. Because what this slide is showing you is if the patient has an NIH score less than 20, age less than 70, no ischemic changes on CT, and a glucose less than 300, they have less than a 2% chance of symptomatic hemorrhage. Okay, so be wise and inform your patient. But don't tell that young patient who has a foramen ovale who flipped a clot that he has a 6% chance of hemorrhage, because he doesn't, and you're giving misinformation. And so it's been reanalyzed, and they've come up with the results that I just told you, and other studies have looked at this. And so now we have large registries for the last 15 years that have been collecting a lot of patients. And I can tell you there are several commonalities. Number one, the risk of being disabled at 3 months, if you're not treated, is still about 25%. So we have pretty much established what's going to happen if nothing's done. And all the registries are pretty much telling us that indeed, if we treat, you're going to get up to the 35-40% of 0 to 1 modified Rankin. That's pretty impressive. And the most recent one that's been published on this is a large registry review, 58,000 patients. And this was just published in JAMA this year, and pretty much it's not validating, but it's supporting the findings of the original trial. So we have 15 years of post-marketing data of use of the drug, and this is what we're seeing. We're seeing that. I have 20 seconds to tell you. I'm going to tell you in a second, but I'll tell you from 2006, nobody was endorsing this, and in 2013, we now have a Class 1 recommendation from ASAP-AAN. SAEM rescinds its policy that they shouldn't have written in the first place. We have American Heart giving a 1A recommendation, American Stroke. We have ASAP and AAN, and they've all come in endorsing, having reread this literature, and pretty much showing that it's valid. This is the recommendation by the American College of Emergency Physicians, and AAEM gives the same level recommendation. And basically, it's created a standard. And so the key points are this. It is the standard. There's good data to support its efficacy. The risk of symptomatic hemorrhage is dependent on the subset. If I have a posterior circulation stroke, I have several large registries showing that the risk of symptomatic hemorrhage is about 1.3%, with placebo being 0.6. Posterior circulation strokes don't end up hemorrhaging. And if you decide not to use it, God bless you. It won't be on me, I hope, because I wouldn't be happy. But if you make that decision, just make sure you've documented it really well. I apologize, I went over.
Thank you so much. Round of applause. Let's get Anand up there.
I have so much more to say. Could I buy some time from you?
Yeah. No, that's unfair.
All right.
So I will say for the record.
No. Be on record. I want you to be on record.
Now I know why Andy wined and dined me last night, since he was under the impression that a cage match was a little bit different than the impression I was under. I did try to bring back Randy Macho Man Savage from the dead to be my tag team partner. So this is really the idea that we're debating here. tPA is an effective, proven therapy for acute stroke. So the first thing that I thought about when Scott asked me to do this was, how can I make a joke about Andy Jagoda being the same person as William H. Macy? And I said, hey, it kind of speaks for itself. I don't really have to. And the second thing that came to my mind was this, Saturday Night Live, point counterpoint. For those of you guys who haven't seen this, I strongly encourage going to watch it, but this isn't what we want to do. We don't want to have name calling. We want to look at the data and really talk about what that data means. So I will try as much as possible to not call Andy an ignorant slut, but if it happens, so be it. And this is the crux of the matter, right? The clinical policy for the use of tPA as given by ACEP. And when we look at this, there's two major recommendations here. Level A recommendation is that it should be given to patients under 3 hours based on the NIN study, and for 3 to 4.5, it should be offered or considered based on the ECAS-3 study. I think these recommendations are simply bad medicine. I think they're based on bad studies, and we'll talk about why. But the main thing that sticks out to me is you don't usually make a level A recommendation based on a single study, but that's what ACEP did. And you don't make a level B recommendation based on a single study, but that's what ACEP did. I don't think that's good science. And this is what we're worried about with tPA. This is why we talk about it ad nauseum. I disagree with Andy. I have seen them bleed in front of me. This was clearly created for neurologists because they had to point out which was the front of the head and which was the back of the head, just in case they weren't sure. And so as all drugs, this has risks and benefits. And so the three major points that I see is, one, we don't know which patients to give tPA to. Two, we have been told by the experts to ignore a host of evidence. We've been told that there are 2 studies that are really good and we should pay attention to those, and there's a bunch of literature out there that it's crappy, don't pay attention to those. That's what we've been told over and over again. So I want to go back in time a little bit, and I want to look at some of these studies. I'm not going to do an in-depth review because I only have 10 minutes. We're just going to very briefly touch on each one with their primary endpoints. So MAST-I in 1995, no benefit. ECAS-1, 1995, no benefit. Then came the NIN study, and Andy was very forthcoming about the fact that this was 2 studies, not 1 study. So part 1 of the study, they had about 300 patients under 3 hours. The outcome they were looking at was improvement at 24 hours, and they found no benefit. They stopped the study, they data mined that first 300 patients, and they said, where can we find an outcome that's positive? Where can we find something that works? And then they restarted the study, enrolled another about 300 patients. Again, the time was the same, 3 hours, and now the outcome was 90 days. Not 24 hours, but 90 days. And they found an NNT of about 8. So what's wrong with that? If this study came out today, no one would look at it. You do not go halfway through a study and then change your primary outcome. That's not how research works, but that's exactly what they did. There are other flaws with this study. You had to enroll 1 patient under 90 minutes for every patient over 90 minutes that you enrolled. Who in this room has given tPA to a patient who presented under 90 minutes with their CVA? That is not a lot of hands. So that is artificial. That is not what real life is. They also found this intracranial hemorrhage rate, 6%. So a number needed to harm of about 16. And based on this, the American Heart Association gave a recommendation that we should be using tPA for ischemic CVA, based on 330 patients. How many patients did they base the recommendation for tPA or thrombolytics for MI? We have 60,000 patients on that side, right? So 330 versus 60,000. That's a big magnitude of order of difference. And so I think this is bad medicine. I don't think they made up the data, but I do think they distorted it, and I know they data mined to find something. And so this is the problem that I have with the NIN study. You can't go back and look for something and then start the study again. It just doesn't hold water for me that we should even be paying attention to it. So moving on past NINs, MAST-E, harm, stopped early. ASK, the ASK trial, harm, stopped early. ECAS-2, no benefit. Atlantis-B, this was done by Genentech, Boehringer Ingelheim. Harm, stopped early. Atlantis-A, which came out after Atlantis-B, that's a weird thing you guys can read about, but harm, stopped early. And then lastly, the DIAS-2 trial, which showed no benefit. Then comes ECAS-3. So ECAS-1 and 2 didn't work. Let's take a third shot, third time's a charm. 3 to 4.5 hour window with alteplase. And they found more favorable neuro outcomes with no mortality difference. A number needed to treat of about 15. What's the problem with this study? They retrospectively excluded patients that had large territory strokes. So basically, they enrolled them in the study, they gave them the drug, and they said, well, we shouldn't have given those people the drug. So we're going to take those out of the analysis. They changed the definition of a symptomatic intracranial hemorrhage. So they didn't like what the definition was, because it didn't work for them, and they changed it. The other big problem with this is they used the modified Rankin score, which Andy talked about, and here it is. They used the modified Rankin score, and they said if you had a 0, 1, or a 2, that was a good outcome. That's what we were looking for. If you had a 3, 4, 5, or 6, that's a bad outcome. Now let's look at this and see if this makes any sense. If I have a moderate disability, but I can walk on my own, that's the same as being dead. Does anybody think that's true? Andy himself said that's not true. He said a modified Rankin score of 3 is a good outcome. So let's shift this data, and let's include 3s with 0, 1s, and 2s. No benefit to tPA in the ECAS-3 trial. Moving on, IST3, just about 2 years ago. This is the largest randomized study. They had a window of 0 to 6 hours, which you saw done a couple other times in the past on other studies. No difference in primary outcome. Short-term mortality was increased by 4%. So if you wanted to wave goodbye to your family member a little early and get that inheritance, 0 to 6 hours, go ahead and do it. Other problems with this study, there was no placebo arm. It was tPA versus no treatment. So this was open label. Everybody knew what they were getting. There was no placebo done. These are the things that favor the study, right? In addition, more patients in the tPA arm had ICU care, so they had better care done for them. So all of these things were biased to get a good outcome, and they still couldn't get a good outcome, which hints to me that what they actually had was probably a worse outcome in the 0 to 6 hour window. And so when we look at all of the studies together, we've got 10 studies that are no benefit or harm, and only 2 studies where there's a benefit. But what we've been told over and over again by the experts is that NINS is special. NINS is the study that we should be paying attention to. It's sort of like the one study to rule them all. As far as I can tell, that's what the experts agree on. So let's see if it really is. The couple of things that they focused on in NINS was that time is brain, under 3 hours is the magic number, and alteplase is better than the other lytic agents. So let's talk about whether time is brain. IST3 says no. 0 to 3 hours, small benefit, 3 to 4.5 hours, harm, over 4.5 hours, benefit again. That doesn't make any sense with the time is brain idea. And the Cochrane review came out, and they did this in 2009. They said no difference across time windows. 0 to 3, 3 to 4.5, 0 to 4.5, 0 to 6, 0 to 12. It didn't matter. No difference across time windows. So time is brain is out. How about alteplase, tPA, being different? It is different. This is the Gusto trial back in 1993 looking at MI. And what they found was that patients who got alteplase had a slightly higher intracranial hemorrhage rate than the other thrombolytic agents. So I agree. Alteplase is a different drug. It is special because it is more likely to make you bleed into your head. And the Cochrane database again got together in 2013, and they said no difference one lytic agent to another. That's dose, that's type of lytic agent. This is a class issue, not just alteplase is better than streptokinase. So time is brain, out. Alteplase is better, out. So I think we can finally say we can let go of that one study to rule them all. We need to drop it and move on. Okay, so if we drop it and move on, we have to now pay attention to the other 10 studies that have said no harm or benefit. And remember, these are all done in a study protocol, right? So we know that there are other factors that come into play, the Hawthorne effect, which always makes studies look a little better than real life. This is the Cleveland area experience back in 2000, looking at when they used tPA in their community, how did patients do? 16% symptomatic intracranial hemorrhage rate, not 6%. 16% mortality rate, which was larger than the tPA group. They also found a 50% protocol violation. And so all the neurologists said, ignore the Cleveland area study. These docs are too stupid to know who to give the drug to. It's not the drug's fault they gave it to 50% of the wrong people. But the neurologists can't do it either. So this is a nice study looking at stroke neurologists versus neurology residents versus EM physicians and saying, can we all agree on what a stroke is? The answer is no. We cannot all agree on what a stroke is because there are stroke mimics. This is a caterpillar that looks like a snake. I don't know, I still think it's a caterpillar. But there are stroke mimics. Hypoglycemia, seizures, tumors, conversion disorders, and TIAs is one of the big ones. So if we can't figure out what a stroke is, how can we treat them? And remember that the NINS trial did tell us one thing. If they have symptoms that resolve within 24 hours, congratulations. You didn't lyse a CVA, you lysed a stroke mimic. Now this is the TREAT task force. These are a bunch of experts with no data who say that if you have rapidly improving symptoms, but you still have symptoms, you should give tPA. So they are advocating the use of tPA for TIA based on no data, but some money involved here. They're all paid by Boehringer Ingelheim to make this recommendation. And this is the logical end to an illogical statement. This is a case report of a patient who had a TIA, all symptoms resolved, but they had ischemia on MRI, and they gave that person tPA. How can you get better than perfect? They tried. And so the bottom line here is this is bad medicine and bad science. You can't ignore data you don't like. There are 10 other studies that say we should not be using this drug. We don't know who to give the drug to. And so when we go back and look at the host of the evidence, we've got 10 studies against and only 2 in favor. If you have any questions, please send them to either my email or my Twitter account. And remember, knowing's half the battle.
All right.
Andy, we're going to give you 5 minutes to tell him how wrong he is.
Only about tPA you can tell me how wrong I am.
I ran out of paper. So I guess I should begin by saying, if anyone thought that caterpillar looked like a snake, you shouldn't be giving tPA. I agree. I happen to agree there. So it does come down to good clinical skill and knowledge and the ability, indeed, to recognize what you're treating. If you can't recognize a right-sided infarct, yeah, you shouldn't be giving nitroglycerin because you're going to kill the patient. And that is medicine. It's interesting, this is a recurrent thing when you read about this literature, people lumping, and I, of course, was criticized making a decision on one well-designed prospective study and then a lot of phase 4. You do have to understand how guidelines are developed. You don't need necessarily only level 1 studies to make a level 1 recommendation. Everyone knows American Heart and American Stroke has a 1C recommendation, which is in essence thought to be best practice, but based on consensus. So you have to understand how guidelines are developed to understand what drives the creation of a level 1 recommendation. But that said, I'm not going there because it isn't just consensus that's behind the use of alteplase. There's the NINS trial, which is 2 parts, was combined. It can be looked at as 2 studies. But then we have a large number of registry data, which would be phase 4, a large amount. And like I said, if you can get with the guidelines, 58,000 patients. If you look at SITSMOST, 6,000 patients. We have well over 70,000 patients now in registries who've gotten tPA that are pretty much all paralleling the findings of NINDS. It bothers me a little bit that what's being presented to you is 10 trials, and we're going back to MASS and ECAS-1. These trials didn't use alteplase, you probably know. They used streptokinase. And they were going out to 6 hours. Why are we mixing and matching a lot of studies that aren't congruent? I mean, it really catches me off balance that you're going to tell me that you're going to look at studies that looked out to 6 hours that were using streptokinase. You didn't tell them that. So they think that you're comparing the alteplase, one drug, with another drug. That's a little bit unfair, and that's what these guys do out there as they try to kind of get you seeing the world through their eyes. I have numbers behind me, lots of numbers with these outcomes. And there is a risk, and I'm telling you again, you do need to be a good clinician. If you're not comfortable with doing a neurologic exam, yeah, maybe you shouldn't be making decisions that are going to impact that patient. But I think our specialty has now gone forward. We're teaching the neurologic exam. We're teaching that competency. And I think if you're smart and able to select the right group, as I've shown you, you can actually minimize the risk that the patient's being exposed to. But we're still back to, I think there's 2 things on the table. One was the risk, but I also am not hearing, even in any subset, you don't believe that there's benefit. And I think that's ignoring a fair amount of experience and literature that's out there. We're not going to settle this, and again, I'm out of time, but we're not going to settle this in this brief debate. I think all of you as residents are being given the tools to read the literature and to analyze yourself. This is the challenge we have in making decisions. These are interesting studies, and so you should pool them and read them and also try and understand for yourself. I'll go back to Cochrane because we all like to reference Cochrane as being fairly authoritative. That analysis, it's a systematic review. It's not a meta-analysis because the trials are so different. And of course, its criticism, again, is they're lumping, mixing and matching streptokinase, urokinase, and alteplase. They all have a different mechanism of action. They have a different length of action. And you know, everyone's always quick to say 60,000 patients in the cardiology trials. But if you talk to the methodologists, they're saying the stupid cardiologists, they could have stopped at 5,000 because they had sufficient data to make the decisions and other patients would have benefited. So this kind of thinking is just a little bit abstract for me. It sounds good in a debate, but I actually think that's not good science.
The gauntlet has been thrown.
All right, my friend, you get 5 minutes, and then we'll bring them both up and hear what happens when they're right next to each other.
So that's fine. I think Andy did call me an ignorant slut, just in his own way.
In a very polite way.
So I'm sorry. So the first thing I said was that I think I was very honest about what drug was being used in each study. So you can go back to my slides and see that. That's the first thing I'll say. The second thing I'll say is, I think the reason why we have 60,000 patients for those MI trials, the reason it was replicated is because one study does not prove something. You need to replicate it. NINS has never been replicated. 330 patients done once. It's never been replicated. Atlantis A and Atlantis B was sort of a replication. It was meant to be a replication. It was also sponsored by Boehringer Ingelheim and Genentech, and it was meant to be until the tPA got approved by the AHA. And then they changed the study because they said, it's already approved. We can't do any good to ourselves by doing another study, because what if it comes out as it doesn't help? So it was sort of the only attempt to replicate it. So I would say that while I think Andy has a good point that we don't want to just keep replicating things ad nauseum while we're giving patients sort of the bad end of the drug, we do need to replicate them. We need to replicate the results to show that it works over and over again, and we haven't done that. And again, the reason I would say you can look at all these studies is because the Cochrane database says that the agent doesn't matter, the dose doesn't matter, the time window doesn't matter. So we can look at all of that data when we have to make a decision. And this is a pretty critical drug. This isn't like, I'm going to give some, I shouldn't say I'm just going to give some normal saline. I caught myself. This isn't just, I'm going to give a little Reglan for nausea. This is, I'm going to give a drug that potentially can make this person bleed into their head. Yes, there may be a benefit. And I'm not saying that tPA is a drug that doesn't work for anyone. What I'm saying is that we don't know who it works for. And the way that the studies have sort of rolled out and the recommendations have come out is that it has precluded researchers from figuring out who the drug works for best. There may be a subset of the population where you give tPA and they all get better immediately. But we don't have that data because NINS and those things were pushed on us instead of us looking at the data over and over again to find what the right population was. So yeah, I agree with Andy. I think there is a population that it works for. The point I disagree on is I don't think we know who that population is, and that's what we need to sort of try and figure out is who this drug is the right drug for. As far as what you're actually going to do, that's a very different situation. So I don't want to come up here and be like, the next time that I have a stroke that comes into my department in 90 minutes, I'm not giving tPA. That's not true, because you have to do what your hospital says. That's not what Andy and I are up here arguing. What we're arguing is the merits of the scientific literature. And the merits of scientific literature here, in my opinion, are not that strong. Now, Andy talked a little bit about visual reanalysis that was done. If you want a really good visual reanalysis, you can check out Jerry Hoffman's visual reanalysis, where he sort of shows over and over again through multiple different visuals that there's no difference in using this drug in the NINS trial. So it just depends on who you ask. We all know statisticians can use stats to prove anything they want to, right? So if you ask Jerry Hoffman, he'll show you 100 visuals that show there's no benefit to the drug. And Andy showed us one that it does show there's a benefit. I don't think that's enough evidence to go on. So I don't even think I need my whole time here. The main point that I would have is I do think this drug is right for somebody. I just don't know who it is. And I wish that instead of us just sort of cutting it off and saying we have 330 patients in one trial that says this is a good drug, that we had replicated that study and we had done more research before we had embraced the therapy. And what I would caution people is we can very easily slip down the same slope. So we had a little discussion last night about neurointervention for CVA. And if you guys remember, just less than a year ago, 3 studies published in the New England Journal, all showing the same thing. that this drug, that the devices did not work. They did not decrease the rate of patients who had larger strokes or death or any of the other things. And this is sort of the slippery slope that we can slide down, is that they're going to keep doing this study. They're going to keep looking at devices until they find one that works. We should not embrace based on one study. So if one study comes out saying, I made this clot retrieval device and it worked, we should ask them to replicate it again and again until they show us over and over again that it does really work. And the last point I'll say is that MI and stroke are different. In an MI, it's an acute clot, and so a thrombolytic agent works. That makes sense. Some strokes are acute clots. Some of them are old clots that have been hanging out in your left atrium for like a year or a couple of months. And lytic agents don't work on clots that have been formed and are chronically there. So that's the difference, to me, between CVA and MI. One of the critical differences of why this drug does not work the same way it does for MI. I think that's it. Thanks, guys.
Have a seat. All right, we have about 10 minutes. I want to pose the first question to Anand. So one of your colleagues, you're in the department, you're working a double staff shift, all of a sudden becomes aphasic, says can't move his right hand, can't lift his arm. 10-minute mark. CT's negative. You gonna give him TPA?
So, since I have to rest on what I've already said, the first thing I'll say is the time window doesn't matter. I don't like all of my colleagues, so can we say which colleague? No. Okay, so, Joe Lex has a really famous quote, and he says, if I can't kick the syringe of TPA out of your hand, go ahead and give it to me. So I feel a little bit differently about it. Give me the TPA, and then if you see a little spot of blood, just keep giving me more TPA until blood starts shooting out of my ears, because I want to be done at that point. So would I give it to them? I'm working at Bellevue or NYU. We have a protocol, and it's not my decision to overrule a protocol that's been formed by a hospital. If it's up to me, would I give it to them? I would counsel them and tell them the pros and cons of this drug, which I think is a big part of our role, is to be in the room when neurology or whoever else is consenting them for this drug and make sure that both sides are being presented. So I would give them both sides. There is a benefit, there is a downside. What do you want? And I would let them choose. Now, if it was me having the stroke, what would I do? I don't want the drug.
See, I would take it. And even though I do have equipoise about this. Andy, I want to hear from you. What do you tell your patients about the risks and benefits? How do you portray this? Because they'll answer whatever we want them to, depending on how we present it. If we tell them it's a fantastic thing and I take it myself, then they'll probably take it. If we tell them it's horrible and the work of the devil, then they won't. And so what is your honest assessment of what we should be telling these patients?
So we're back again. There is some risk stratification that you can do. And in the scenario, the young colleague, my guess, if they have a normal CT, I'm assuming aren't hypertensive, their glucose isn't out of control, right? They're under 70. And so, in essence, the stroke, the risk of a hemorrhage, symptomatic hemorrhage is less than 2%. So number one, I want to make sure I'm communicating to them what the risk is. That's different than grandma who is NIH stroke scale score of 20 or has some changes on the CT. The risk of hemorrhage actually can be up as high as 17%. And so then one has to be presenting to the family what was the wishes of the patient. The dilemma we would have, of course, is if there's no family present, and we'd be having to make that decision ourselves. And I think that's a very hard scenario to be in. For the young patient, and there was no family, and they weren't able to consent for whatever reason, I'd be giving it to them. I don't mind being a little paternalistic and making those decisions. For the older person, I'm not sure.
Well, let's get to that. Let's zone in on this. So 82-year-old comes in, no family, and they're not able to participate in the conversation. They're basically high NIH, and they're not responsive. You're going to give it because you're going to err on the side of giving, or you're going to not? And what are you going to write in your note to protect you if you decide not to?
Yeah. So I'll tell you, once again, we have to take all the risk factors for hemorrhage. What's their glucose? What's their blood pressure? You've told me the age. And what's the CT? And once I'm going to be giving this drug. If I'm not giving it, I'm going to be writing a note very clearly. that risk of hemorrhage and death. Because remember, if you have a symptomatic hemorrhage, it's a 45% mortality. Right? So there's reason to be very respectful of this drug, don't get me wrong. But if this person already has an NIH stroke scale score of 20 and above, I'm over 17% chance of hemorrhage, I could be justified not giving it, but I'd be writing that down. You don't need informed consent signed to give tPA. If it's FDA approved, most stroke teams now don't get informed consent as a mandatory thing. You need to have a mandatory conversation with someone, hopefully, but you don't have to get a signed informed consent.
Anand, I have to do a signed informed consent for a lumbar puncture. Is it acceptable to not get a signed informed consent of some sort for tPA?
I don't think so. I think it's reasonable to get an informed signed consent for these patients if you have the ability to do so. Andy's right, some of these patients won't be able to consent, you won't be able to get family, and then you make the best decision you can, as we do every day for multiple different things. Major trauma, we don't consent them for that CT scan, we get a two-physician consent, so sometimes you have to do that. You know, first of all, is the 82-year-old the same 82-year-old that fell off of Rich's roof? You know, that's going to make a difference to me. How functional was this 82-year-old at the beginning? And, you know, IST3, if I remember correctly, larger strokes and older patients did better than smaller strokes in younger patients. So, again, there's some inconsistency with the data that is out there. If I have a stroke scale of 20 or 25 and I believe in the drug, I think that's when I would want it. If I can't move half my body, I can't speak, that's much more important to me than a stroke scale of 3 where I can't move my pinky or something like that. So, I mean, I think if you believe the drug works, which I obviously don't, but if you believe it works, I want it for the big stroke. Because if my life is going to be, I can't move half my body, I'm going to be dependent on somebody for the rest of my life, someone's going to have to wipe my butt for the rest of my life, maybe or maybe not, I'm going to need a peg. I'd rather take the 17% risk of bleeding to my head and going off into the night early.
All right, let's hear from the audience. Yes, Faust.
So of all the controversies in emergency medicine, this may be the only one where there's a level A clinical policy guideline. There's a debate about a level A. If you look at the ACEP clinical policies for a variety of things, a very common recommendation is no recommendation. And then level B and C are things that we do very often. My question is, do you guys feel that maybe the controversy is about the level A? So my specific question for both of you is, how would you feel if the same language became a level C or level B recommendation, level C being inconclusive or things that we believe are good, but there's conflicting evidence, things of that nature?
So just a little bit of history. So you know, ACEP came out with this policy. If you haven't read it, it's a nice analysis of the literature, and it gives this recommendation I presented to you. Level A meaning this was a joint venture between American Academy of Neurology and ACEP, and endorsed by the Neurocritical Care Society. So 3 different groups have looked at this literature, and they pretty much agreed that it was strong enough to give a level A recommendation. That's great. This is amazing. This is the politics of practice guideline development. So, okay, they come up with this recommendation, and what happens? The counselors meet at Scientific Assembly. Do you all know this? Because this is amazing. Counselors meet. Who are counselors? Well, counselors are a lot of people who are older and don't know what else to do, so they become a counselor. Oh, I hope that's not on tape anyway.
No.
So, okay, so what do? They have a vote. This is unheard of. So we have a methodology. We generate an evidence-based guideline with graded evidence. Make the recommendation, and the counselors vote 75% for the board to rescind the policy. That's unheard of. That's never been done. And so you can't rescind the evidence that drove the policy. You would. But this is what so right now the ACEP board is meeting next week, and this is on their agenda to figure out what are they going to do with this counselor's recommendation to rescind, and let's try and reinterpret the evidence. And like you say, well, maybe it's not really class A. Maybe they made a mistake, and the Japanese and the Australians and the Europeans and the Canadians and everybody else, maybe they all made a mistake grading the evidence. Isn't that's craziness? But anyway, stay tuned for that. That's coming up. And so what if it was a level C? But it's not a level C. So you can't develop a guideline and politically just try and word it so people are happy. It is or it isn't. The decision was made, because you weren't on the committee, And that was maybe an error. Actually, I have to tell you, that was a mistake. If I look at how this committee was put together, it was a mistake, because who do you pick to put on committees? The foxes. I get it. I understand that argument. And there should have been a different group, maybe with less bias, on that committee. But regardless, it was graded A. You can change it. So you can't say, what if it had been a level C? No, it's not a level C. The evidence is level 1, say some people.
So what I would want for a level A is multiple randomized control trials showing the same thing, which I don't have. And I agree with Andy, you can't change it now necessarily. You have to reconsider how you're going to present it. I'll also say that I like some of the wording of the document too. It should be offered to patients who are under 3 hours. It should be considered in patients 3 to 4.5 hours. So Andy said that the recommendations aren't done politically, but they are done smartly. So that's much smarter wording than if the patient comes in 0 to 3 hours with a CVA, you should give the drug, because that makes you look really bad for a lawsuit. So ASAP didn't throw us all out to the wolves. So there's a lot of animal analogies going on.
No,
Foxes
right.
and wolves.
Caterpillars,
Caterpillars
snakes.
that look like snakes. So I'm not a fox, as you suggested.
No, I didn't suggest that. You're very sensitive. You're way
All right, now they're starting to comfort each other, so that's the time to cut it off here. I want to hear from you guys now. So, if there was no malpractice worries, no litigation, and no institutional policies dictating your behavior, just based solely on your own clinical practice, how many folks are going to give tPA to the patients who come in with an acute ischemic stroke? Show of hands.
No. You have to give them a little better.
No, I
scenario.
don't.
Yeah.
I don't, because the guideline says should be offered.
Yeah.
And so I think, and they didn't make all the provisos. So just as a generality, I just want to know, all comers, if you're going to lump them all together, give tPA, not give tPA. All right, so we solved nothing. All right, but it was a fun trip to get there. Can I have a round of applause for both of our debaters, who both did a fantastic job? And the one thing I will disagree with you on, Andy, is I think there was room for this debate. I think this was very enjoyable. So,
Thank you.
good stuff. All right, we're going to go right to the blast, the final portion of the day. So can I get my blast competitors up here? What's that?